Our next speaker is Michael Brennan. Michael is chair of the Productivity Commission, which provides independent research and advice to government on economic, social and environmental issues affecting the welfare of Australians. Michael previously served as Deputy Secretary of the Fiscal Group in the Federal Treasury and Deputy Secretary of the Economic Division in the Victorian Department of Treasury and Finance. He's worked as an Associate Director at PricewaterhouseCoopers and as a Senior Advisor to Treasurers and Ministers for Finance at the state and federal level, and survived, it seems. Michael will be speaking to us today about the concept of a healthy population and healthy economy. Welcome, Michael.
Thank you, Karen, and thank you all. You can hear me okay? And Angus, that's a tough act to follow. After that heartwarming and authentic personal reflection, then I get the introduction as, you can tell I'm kind of like the economic rationalist from Central Casting, Productivity Commission, Treasury, etc., PwC. But I'm going to try and reflect on a few of the themes that have been, I think, common across the various strands today, a couple in particular, to give you a bit of a sense of how it is that policymakers think through the issue of quantifying the impact of health interventions, where the value is measuring value versus cost, and coming a bit to talking about where the economic dividend from good health comes in. And I'll talk a little bit about innovation. I'll leave most of that to Zoe. I'd like to start by acknowledging traditional owners of the land on which we meet, the Ngunnawal and Ngambri people, and pay my respects to elders past and present. I prepared a few slides and I'm just going to kind of riff off them a little bit. But the first observation to make is that valuing healthcare interventions is a very difficult thing to do, but very necessary. Of course, we're talking about lives, and you're trying to juxtapose the lived experience, the impact on family and friends with these dollar values. And it can inevitably feel clunky, it can inevitably feel cold and calculating. But to some extent, if we're serious about rationing the public dollar across competing uses, we have to have some sense of where the relative value is likely to lie. Health's incredibly costly, and one of the things that's distinctive about the health industry as against all others, pretty much all others, is that technology seems to add to cost rather than to reduce cost, right? In every other sector of the economy, we talk about technology coming in and it effectively reduces cost. It's the automation of production processes in manufacturing or agriculture or whatever. In health, we talk about technology, it raises cost. Now, the dividend from that is that we get high quality, but it's something that we have to think through, right? For the Productivity Commission, we've got a little bit of experience in this. We did a report a couple of years ago, pre-COVID, 2019, I guess it was, reporting early in 2020 about mental health. And one of the key conclusions we came to there when we tried to quantify what is the impact of mental ill health on the Australian economy was that the cost was in the order of $180 to $190 billion. How did we come up with that? Well, a bit like the numbers in the document that you've launched. It's art as much as it is science. But what we were trying to do was use a methodology not dissimilar to what the PBAC would look at when you're trying to think about quality adjusted life years. So what is the cost of lives that are cut short by mental illness, so suicide, premature death, but also the impact of lives lived in less than full mental health. So you get 180 to 190 billion. I'll just make 2 points about it that I think are important. One is that when you looked at that total cost, only a small fraction of it was actually the things that you can count up as foregone GDP. Right, so the actual economic cost in terms of participation or productivity was actually sort of a minority of the overall cost. And I think that's an important point when we're trying to think about what the value of health interventions is. Of course, the economic bits are important. Healthier people, as I'll come to, have a tendency to participate more fully in the economy, participate more fully in the labour market, tend to earn higher wages, work more hours, all of that. But it's actually the smaller part of the story. And the bigger bit is the broader wellbeing impact. And who said that economists don't care about broader wellbeing? It's just hard to quantify. The second point is that it's one thing to kind of total up that aggregate cost or that aggregate burden, $180, $190 billion. We then came up with a series of potential policy reforms, policy interventions that maybe could do something about mental health. When we added up the benefits of those reforms, the benefits do not total 180 billion, right? Because the point is it's fiction or kind of escapist to think that we can somehow wipe away mental ill health altogether at the stroke of the policymaker's pen. Of course you can't. So in the real world, you're dealing in that segment of what's achievable, right? So we felt there was a suite of reforms that could reduce that burden by about 18 to 19 billion dollars, right? Around 10%, which might seem modest, but it's actually pretty significant, right? As policy interventions go, that's a pretty significant dividend. But you can't solve everything. One of the things about the, as I said, highly imperfect, these estimates of the overall burden of mental health. But it does allow you to make some observations, at least at a high level. One of the things about mental health, and rare cancers are kind of an example of this as well, where it's striking people relatively young in life, as mental health does, bearing in mind a lot of disease burden is striking people at a relatively advanced age. Again, totally kind of cold and calculating, but that's a lot of years of future life that are affected by ill health. And that's part of the reason why the burden of mental health and why the burden of childhood cancers is so large. And you do want to factor that a bit into the sort of formulations you're making, the valuation of competing interventions. You do want to try and reflect the fact that where something hits young people, it's likely to have a longer lasting impact. I'll just rush through a few of these things just to make a couple of broad points. Firstly, on broad value, Australia spends about $200 billion a year on health. That's a little bit over 10% of GDP. It's a lot, and it's rising pretty dramatically. But when you step back, we probably are getting, overall, by OECD standards, pretty good value for the dollars that we spend. Australians' life expectancy is a little bit above the OECD average. Our spend as a share of GDP is about on the average, maybe a little bit below. When you do a chart that tries to map our spend as a share of GDP against life expectancy, compare it to all the OECD comparators, we do better than you would expect. You know, we do better than that relationship would normally expect. So we're getting good dividends in many ways out of the health spend. And if you think about where we've come from over 100 years or so, we've had major inroads into childhood mortality, infant mortality, major inroads into life expectancy, which has gone from about 40 in the early 1900s to high 70s, low 80s today. So it's a pretty good deal. The question is, for the marginal dollar, what are we getting? And what are we getting in different interventions? And I'll just make this observation about the health system. You're very familiar with the PBAC process. You're very familiar with the health technology assessment process. For people like me, that process is, as frustrating as it is for many of you, there's a kind of a comfort associated with that at least it does have a sense of rigour, right? It is trying to get at what is the cost per quality adjusted life year of different pharmaceuticals. Different parts of our health system have that rigour built into them, but a lot don't. And when you think about where most of that $200 billion is flowing across our health system, a lot of it is happening a little unthinkingly, right? We have programs like the MBS, programs like activity-based funding in hospitals, range of other demand-driven programs, even the PBS, because there's no cap on how much is used once a drug is prescribed in aggregate. So a lot of the dollars that are flowing are a little bit unthinking. It's not as though we're sort of sitting there really thinking about every individual dollar. And the second observation I'd make is, for the most part, Australia's health system, and this is partly a virtue, but not entirely, is one that funds activity rather than value. So we fund people to go to the GP, we fund people to go to specialists, we'll fund that on an activity or a fee-for-service basis, we fund public hospital activity, again, on an activity-based funding basis. That's been a very important process for driving a sort of sense of technical efficiency. Funding hospitals for what they actually do reduces cost to an extent, but we don't always have a strong sense of value. What is it that we're really getting? We're getting a lot of activity, or we're getting a lot of value in terms of health outcomes. One radical approach to thinking about value in the health system is to ask people what they actually want. The slide here I've got refers to a consultation that involved a large-scale survey with 6,000 participants, asking them, what is it that you really want out of the health system? The key priorities were mental health, bearing in mind about half of Australians at some point will deal with mental ill health to some extent, being active, but most importantly staying independent and managing one's health condition, particularly for people with chronic conditions. But the health system isn't always necessarily delivering the type of care that aligns with what people value. And the experience with cancer may be quite different to the experience with other parts of the system, but it is interesting we have a health system primarily organised around episodes of illness, a slightly reactive system, one where you present to the system when you've got something wrong and you're going to find out more about it, rather than one that reaches out to you and tries to help you proactively or preemptively manage things before they emerge. So it is worth asking what a different looking health system might be. What might a better health system look like? Not just one that's sort of better on some sort of technocratic measure like the ones that I've already outlined. When we did the last 5-year productivity review a few years back, shifting the dial, we talked about these various attributes here, but the most important element was empowerment. The idea that a system should be centred around the individual, so it should be less fragmented between a whole bunch of different systems, an acute system that's over here, and then a primary care system that's over here, and maybe allied health over there, and some other social supports over here. We did refer to this little anomaly, the idea that it's a peculiarly health thing to have a waiting room, like the idea in any other service sector that you wait around for the practitioner to kind of see you. Well, that's kind of foreign in most of what we think of as consumer, customer, patient-centred service delivery. But the sense of coordination, both through data, but also just through practitioners kind of having genuine team-based approaches around the individual were pretty important and significant elements of what that ideal system might look like. I'm just going to rush through a couple of these other things. I won't deal with them today. It was basically we had some work that we did primarily around chronic health conditions that was really aimed at illustrating the extent to which there is a lot of on-the-ground innovation that goes on in the health sector. And a lot of it's not all that sort of technologically whiz-bang. A lot of it is just making use of pretty simple technological tools, text messages, ringing people up, asking them a few questions, triaging how they're going. We had a look at a bit of software that some GPs developed on the Gold Coast that was basically just very basic data analytics, just mining GP information to kind of provide a few sort of preemptive or predictive warnings about individual patients. This person might need this checkup, this person is at high risk of a hospital admission, etc. And the broad point was that on the ground there is a lot of innovation going on in the health sector around developing this more value-based, more integrated system, but for the most part it's by people who are rule breakers rather than rule followers. And it's often, as I say, not particularly technologically sophisticated. It's just people using the tools that they've got to drive a better outcome. But I'll just spend a couple of minutes talking about the thing that you kind of really wanted me to talk about, which is what is the connection between health outcomes and economic outcomes. And I'll just give you a few illustrations, particularly focused on labour market outcomes, that just show the starkness of what the difference is in terms of a person's labour force participation, employment prospects, earnings, when they're in good health versus when they're in poor health. And to reinforce that point, as I mentioned at the very beginning, this is a minority of the value of good health, right? This is the very narrow economic lens. But thinking in particular up here about the people who I'll call of sort of prime working age, which is, I think we're saying 25 to 49 years, and that counts me out. I'm not in that cohort. But for people who are in poor health, their participation rate in that age group was 43.4%, very low participation rate compared to 88% for those in good health. The unemployment rate for such people, 25%, compared to an unemployment rate for others in good health that around sub 4%. This is slightly outdated, so now that unemployment rate for everybody else would be even lower. There's also the tendency just to work fewer hours. So where people are in the labour force, if they are in poor health, they're tending to work part-time and fewer hours at that. So 43.9% of those in poor health were working part-time compared to about 27% of those in, this is self-reported, but good health. And you can calculate for different areas of disease or disability or illness what the participation deficit is. Like, what's the gap between the people who don't have that and the people who do? Now, for cancer, that was about 15.6 percentage points for people who, this is for people who are 25 to 54 years, and 26 percentage points for those 55 to 64. So it's the equivalent of saying, if the participation rate was 75% for everybody else, it's 60% for those with cancer. It was bigger for some other chronic conditions. It was bigger for osteoporosis. It was bigger for extreme mental illness. It was bigger for stroke victims, etc., but not insignificant for cancer as well. Where mental health comes into it as well, and of course often there are comorbidities with a health issue towards mental health as well, where there's a psychological disability, participation rates can be as low as 28% compared to 83% for those without. And of course there is a flow-on impact on carers, because carers have lower labour force participation themselves, around 56% compared to around 80%. So these are some of the things that contribute to those large estimated gains from improving poor health, or at least making some gains in terms of improving health, and the dividend that you get. And as I say, that's the economic dividend. The broader quality of life dividend is higher still. When we did Shifting the Dial, we looked at a range of estimates of what might be achievable. We thought that a better health system, or more efficient health system, could save in the order of about $140 billion between 2020 and 2040 in net present value terms. It's probably as large a dividend as exists anywhere in the economy, just purely because health is such a large share now of the economy, large share of the government spend, and such a significant enabler of increased participation and productivity. I'll just finish on this observation, because one of the things that is, of course, relevant is all of the social determinants of health. And I guess one of the things that people will point out when I've cited, for example, all those stats on low health status equals low economic participation, etc., is that people can make the observation, well, are you sure that the causation's running that way, or is it running a bit the other way? The people who are not participating in the labour force tend to therefore have lower health as a consequence, or more to the point, is it just correlated with some third thing? It's not that you're actually causing participation by boosting health. There's something in that, and it's a similar point to this, that a lot of what is driving health outcomes, or health outcomes are highly correlated with a range of other things: poor housing, low economic participation, poor built environment, low educational attainment, etc. Problematic social environment, being in the criminal justice system, all manner of things. And yes, you can sort of point that out. And I think that's an important observation to make. I don't think it undermines the case for strong investment in health. What it undermines is the idea that that health is at some level something that's fundamental, that you just change it and then all of the other things will fix themselves. It's not that we believe that. It's that we believe all of these things are kind of co-determined, they're all mutually reinforcing, but the optimal policy strategy is to be addressing all of them in their own way, and they will all to an extent be mutually reinforcing. So to finish off where I started, the task of making assessments about the value of various health impacts, as you know, is challenging. It's important not to take the estimates that one gets totally literally, but they're nonetheless important. It's important to impose a little bit of rigour so that we can make good, sound judgments about where health interventions might be of the highest possible value. But as I say, I think there is a strong case for the fact that a stronger and healthier population has significant economic dividends and significant social and personal dividends that go beyond that. Thank you very much.